We are live now, doctor.
Thank you. So welcome everyone and welcome to the late night Retina episode 34, which is about giant retinal detachments and dialysis. We have today Dr. Shishir Varghese, who is our host and the moderator. Dr. Shishir is working presently with Amita Eye Hospitals. Dr. Shishir is an excellent VR surgeon, and you can catch him on YouTube and Instagram. So over to you, Dr. Shishir, without wasting any more time.
Yeah, thank you, Dr. Avnish, and good evening and welcome everybody to this late night Retina 34 episode on giant retinal tear management. So we have an esteemed panel with us. We have with us Dr. Komal Agrawal, who's a consultant vitreoretinal surgeon at Prakash Netra Kendra, Lucknow. She's also a part of the LNR core group. Then we have with us Dr. Animesh Jindal, who's a consultant vitreoretinal surgeon in Center for Sight Patiala, and we also have Dr. Muthu Krishnan, who's a vitreoretinal surgeon in Arvind Eye Hospital, Madurai. And we have with us two speakers with us. We have Dr. Aarti Mohan Kumar, who's a vitreoretinal surgeon in Rajan Eye Care Hospital, Chennai, and we have Dr. Zakia Anwar, who's a vitreoretinal fellow in IQ Hospitals, Gurgaon. So we welcome all of you. And without wasting much time, we'll move on to our first case by Dr. Zakia Anwar. She'll be presenting a video on giant retinal tear and retinal detachments. Over to you, Dr. Zakir.
Yeah, thank you, sir. I hope my presentation is visible.
Yeah, please go ahead. It's visible.
So I'll be discussing a single case on giant retinal tear management. This is talking about a patient who was a 73-year-old male. He came to us with the complaints of diminution of vision in the left eye since the past 15 days. And on examination, the vision in the right eye was 6/9, and the vision in the left eye was counting finger close to face with an accurate PR. And the pressures were within normal limits. On examination, the anterior segment was within normal limits in both the eyes, except that he had a grade 2 to 3 cataract in the left eye. And on examination of the fundus examination, the right eye was essentially within normal limits. The left eye showed us a temporal subtotal tegmatogenous retinal detachment with a temporal giant retinal tear that was extending from the 2 o'clock position to the 5 o'clock position. It had early PVRB changes as well. So this is the Amsler-Dubois chart, a chart of the two eyes. So in the left eye, as we can see, there was a giant retinal attachment with the posterior flap that was folding, and it extended from the 2 o'clock to the 5 o'clock position, and it had PVRB changes. The right eye, the retina was attached. Seeing all of this, the patient was planned for a combined left eye cataract surgery with PCIL along with vitrectomy. Now, coming to the video, this is our intraoperative video in which we manage the giant retinal tear. So we'll be starting with the vitrectomy per se, the cataract and the cataract surgery is done and the IOL is in situ. Here we are doing the vitrectomy, the core vitrectomy in this case. The core vitrectomy is completed, and we trying to stain the vitreous. Now from here we start the base shaving. So important things in the surgeries in these cases is that the base has to be shaved very properly. The peripheral vitreous has to be trimmed. And as you can see in this case, we are trying to shave as much as the peripheral vitreous as possible, including shaving it from the horns of the tear. As you can see in this case, we're shaving it from the superior end. Here, the anterior lip of the tear, that is, the anterior lip of the retina, is also being shaved along with the vitreous, so that there is no traction that is left. Now that is completed, so we're just checking if it is completely there. And now after that is done, after the base is shaved, we are just securing the margins of the tear with the diaphragm. And because it had an early PVRB changes, we also planned to do ILM peeling in this case to remove any residual traction that was in the posterior pole. After staining the retina with ILM with BBG dye, we will now inject PFCL. The PFCL is injected first onto the optic disc, and from there, going within the bubble, we are injecting further PFCL so that no fish eggs are created, and PFCL fills the vitreous cavity. The PFCL is also filled beyond the tear ends, and in this case, we could see there was a marked shortening. So with the ILM forceps, we are trying to actually iron out as much as retina as possible, as you can see in this case. Once that was done, we did an ILM peel under PFCL bubble. Can we see here? So the ILM within the arcades is peeled completely. And now we are doing laser of the break margins. So in this case, we'll give a nice 3 to 4 rows of laser. And we have to make sure that the horns of the GRT are also lasered, because that is the point where traction can be created later on, and hence the redetachments can also occur from that position. Now, once that was lasered completely, in this case, we are doing PFCL silicone oil exchange. This is done to avoid any slippage of the retina. So as you can see, the extrusion cannula is at the interface of the PFCL and the oil, and the extrusion cannula is we are sucking out PFCL, and simultaneously we are injecting silicon oil from the infusion port. The infusion is removed, and the silicon oil is put into the infusion port, and it's being injected by the assistant, and extrusion is being done by the surgeon. Finally, the last bubble of PFCL is also taken out. As you can see here, the last bubble that was on the posterior pole, even that has been taken out, and the entire vitreous cavity is filled with silicon oil. There was no slippage that was seen, and the case was closed. So on post-operative follow-up, the patient gained a vision of 3/60 on the first day, and his IOP was maintained at 17 mmHg. Even 4 months post-surgery, he gained a vision of his best corrected visual acuity was 6/60. IOP was within normal limits at 16 mmHg. And on fundus evaluation, we did see a mild dyspallor, but the retina was attached underall, and the patient was doing well. So after this case, the points that we would want to discuss is if there is any cause for extensive shortening of the retina, or are there any techniques to reduce the shortening? Any role of cryo to the GRT horns if it's there, or 240 band that can be passed in such cases as in our case? And can FAX be done prior to silicone oil injection, only to increase the field of view or for other cases also? And how do we manage a patient with intra-op or post-op the retina slippage? Thank you.
Yeah, thank you, Dr. Zakia. Great presentation and great case, great surgery. So I would also like to add that we have our LNR co-group members here, Dr. Bhavik and Dr. Sharath also can contribute to the discussion. So anyway, for the first case, my first question is to Dr. Animesh. So she mentioned about that shortening. So sometimes we see the rolled edges of the GRT also, which can be there. So how to manage these rolled edges in a giant retinal tear?
Good evening, Shishir. Yes, a very nice case, Dr. Zakia. And as we see, GRTs, they have a large tears, so that's why GRTs. So the chances of PVR are much more in the GRTs. And even in short duration of detachments, you get those PVR changes. Like in this case, patient had a 15 days duration, and already there was a shortening of the edge. So the most important thing to look for the curved edges is rolled up edges is whether there is shortening or not. If there is shortening, then we have to remove it, because if we don't remove it, then the retina is not going to settle. If there is shortening, the way you did in this case is cryoing you do the cautery at the edge, and then you release that shortened edge or the rolled up edge, so that you have a fresh retina at the edge which can easily attach. If there is no shortening, only the rolled up edge is there, and you are easily able to flatten it out with PFCL, then you need not cauterize the edge and eat up the edge if it is easily unrolling. But if you see there is shortening, then it has to be trimmed with the cutter.
Okay. Yeah. So another thing what I wanted to ask you, so in her video, she has shown the, it's trying to roll the edges with the ILM forceps. Which instrument would you prefer to kind
I
of,
I I usually prefer the soft tip cannula or the flute tip, because with the passive with on the back flush needle, that I have that on the back flush, the soft tip cannula, so that there's a good control. Even if it gets stuck, the retina gets stuck, you can slightly press on the back flush and then release it easily. So I
okay.
usually do it with the flute or the back flute needle on the back flush.
Okay. So now my second question is, now we saw that she also performed an internal limiting membrane peeling. So my question is to Dr. Komal. So any role of primary ILM peeling in these fresh cases of GRT, and in which cases would you ideally do a internal limiting membrane peeling?
So, very honestly, when I personally manage GRT cases, I don't go for a primary ILM peeling in all the cases. Usually, the GRTs, because they have such a propensity of acute reg RD, they present early. And
Yes.
in most of the cases, the PVR has not yet set in. So, usually, we don't prefer doing a primary ILM peeling. Same with how we manage our routine reg RDs as well. But the cases where I would consider doing it would be the cases where the retina has started showing some signs of PVR, especially at the posterior pole. If you see some wrinkling, which is kind of making the retina stiff, or you feel that there is some kind of tangential traction, which is already setting in over the posterior pole or in that area, then probably in those cases, I would prefer doing ILM peeling in the first go. Otherwise, usually, no.
Okay. So my third question is to Dr. V. Muthukrishnan. So any role of cryo to the horns, or is laser is enough? In these cases of giant retinal tear. After your fluid air exchange, or you have filled PFCL up till the brim, would you do a cryo to the
Yes.
horns? Yeah.
No, we do not do cryo to the horns of the tear. I think laser would. So, and as much as possible, 360-degree endo laser is done along with laser for the GRT. 360 endo laser is always done here. And cryotherapy may be an option if there is poor visualization of the anterior edges of the GRT or the horns in specific cases because of posterior capsular pacification or corneal edema, whatever. Otherwise, cryotherapy does not have any added benefit, and we do not conventionally do cryotherapy in GRT cases.
Okay. Okay. So you always do prefer doing a 360 laser rather than just.
We prefer, yes, we do. Yes, yes.
So Dr. Zakia, was a 360 laser done for your case?
No, sir. 360 was not done prophylactically. We just
Not done.
did
Okay.
the temporal side of the GRT.
Okay. Fine. So the next question. So what are the techniques to perform direct silicone oil PFCL exchange in these cases of giant retinal tears? So this is a big question for those beginners, and so this question is to Dr. Animesh. So how do we perform a direct silicone oil PFCL exchange? So that's what she has done in her case.
Yeah.
Yeah.
So like Dr. Zakia had shown in this case, one of the most common techniques that we use for direct oil exchanges, where you detach the infusion cannula and then attach the silicone oil to the infusion cannula. You remove the fluid from the cannula and attach it back. And with the two ports, you have in one hand, the dominant hand, you have the flute needle or the soft tip cannula, and the second hand you have your light pipe. So you keep the flute needle at the edge, at the interface of the fluid and the PFCL. so that it's not in the PFCL. Otherwise, it will immediately suck out the PFCL. So you slowly inject the oil and keep the flute needle or the soft tip cannula at the interface, which keeps on sucking the initially the fluid. So the fluid is totally gone, whatever there is fluid in on the interface. And then you keep the infusion cannula, the soft tip cannula at the edge of the PFCL, so that you slowly keep on decreasing the PFCL bubble and keep injecting the oil in.
Okay.
So in this first we are first taking care of all the fluid in the interface. When there is no fluid left, then you slowly take out the PFCL. So this is a good technique where we are using a 23 gauge or like a 25 gauge or 27 gauge where we have the ports, the trocar cannula, because we can easily detach the infusion cannula and then reattach it by ejecting out the fluid from the infusion cannula, and so that the extra fluid doesn't go in. So if some people are doing with a 20 gauge vitrectomy also, so there the infusion cannula is usually what we say is sutured. So you cannot just take out the infusion cannula, and there's a lot of fluid in the infusion cannula. So if you inject oil through that, first the fluid is going to go in. So in that, chandelier can also be used. So you switch off the infusion cannula, put in a chandelier, and take in oil in one hand and the flute needle or the soft tip cannula in the other hand, and do the same thing. So direct. So in that you can visualize with the chandelier. I prefer
Okay.
using a flute needle instead of, that is a metal tip needle instead of a soft tip cannula for this, because the chances of that getting blocked is very less. This soft tip cannula, sometimes if the oil goes in or something, they get blocked very easily. And but flute needle doesn't get blocked that
Yeah,
easily.
so that was gonna be my next question. So if it gets blocked, then what would you do? So a hard tip
So
with probably.
yes, yes. So even in these soft tip cannulas, you just take the cannula out and just take out the soft tip. It easily comes out. So
Yeah,
it becomes a steel tip cannula.
still tip, yes. Okay. So my fifth question, it's actually an interesting question, and it's there in the chat by Dr. Bhavik. So Dr. Zaki also did it in a case. So any indication for combining cataract surgery in cases of GRT? Any of the panel members can take, or even the LNR core group. Any indication for combining cataract surgery in cases of GRT? And if you're doing cataract surgery, will you put in a lens, or would you leave with them aphakic? And this question has been asked quite a number of times in a lot of forums, and it has been discussed. So what are your opinions on this thing?
So honestly,
Dr.
Shishir,
Komal,
I
yeah,
guess initially when I was starting off, I had a little sort of a reservation doing combining a cataract surgery when there is a reg RD behind. But
yeah,
honestly, nowadays, I feel that once a patient is pseudophakic, it really gives you a better view for your peripheral vitrectomy, for your
yes,
base detection, and especially in cases of GRT to take care of the anterior horns that we were talking about. So if
yeah,
the pupil is well dilated and you're sure that you can do a phaco or a cataract surgery without much trauma to the cornea, and it
yeah,
is gonna stay clear for the rest of your surgery. Uh,
yes,
even with minimal cataracts or sort of NS2 cataracts, which otherwise could have been managed without a cataract surgery, I have combined cataract surgeries along with GRT, or for that matter other reg RDs as well. Does really help, especially with the anterior horn management, I feel. But again, I mean, if it's a clear lens, then probably not.
not yeah. The other advantage is you can completely clear off the anterior vitreous without the worry of a lens touch.
Lens touch, yeah.
Up till, yeah. So, okay. So my next question is again to Dr. Komal. How to prevent subretinal PFCL migration in GRT or reg RDs? So
So
that's a very scary situation where you have a large tear and you have PFCL and scared. You're always scared that it's gonna go behind.
yeah, we feel that this thing is, the tear is large, and so anything that we are going to put inside is gonna go subretinal. It's not like that. It's all about the
Yeah,
vitreous management, I feel. And
yeah,
if we have cleared off the vitreous and any membranes which are over the retina, either pre-retinal or subretinal, basically we've taken care of all the tractional forces which are there inside the eye, then the chances of subretinal migration of PFCL is almost nil. But one other fact which is there is how we are injecting the PFCL. So if it's this is very basic for beginners. You know, anything that you're putting inside the eyes has to be checked outside the eye first. So if you're using a syringe, if you're putting oil, if you're putting PFCL, if you're putting IVTA, you're putting anything inside the eye, first always check it outside the eye to make sure that the needle is not blocked, the pressure which is needed to push things inside the eye is absolutely fine. And then go inside the eye, aim your needle just slightly above the disc or nasal to the disc, and then slowly start putting the PFCL in form of one bubble. It should be slow and steady. It should not be very slow, should not be very fast, should not be, the PFCL should not come out like in small bubbles. Because if it comes out with a force, then again, you know, it can cause a jet stream injury, it can still go behind, it can cause a subretinal migration. So I guess these are the few things that we have to take care of to prevent that.
Yeah. See, other thing
And
is leaky cannulas.
so just one more thing when we are talking of this, and we were talking of rolled edges as well. Just wanted to mention there that when we're seeing the rolled edges, many a times these GRTs can have the edges in the form of a spiral. They are rolled more than once. And I feel not all of them needs to be cut. A lot of it you can, you know, sort of unroll. If needed, you can actually put a chandelier and do a bimanual dissection of the membranes that is forming over the rolled edges. And that can save a lot of retina. But yeah, the absolute edges of those rolled probably needs to be trimmed off.
Yeah. So what is your preferred instrument for rolling?
I just like how Dr. Animesh said, I also use the soft tip. If I have to remove membranes, I prefer it doing I prefer doing it bimanually, because it's a huge flap. So if you're doing it
you can hold
bimanually, it gives you a better control.
Okay. So my next question is to sorry, if anybody would want to pitch in.
One thing that I wanted to ask, like usually we have these GRTs in very high myopic eyes as well. And so in that case, is it preferred that we do the cataracts, do a lens aspiration, leave the patient aphakic, because that gives us a better clear view as well and makes the surgery easier? Is that a case that we can do when the patient is a very high myope and has a GRT there?
Either case, high myope or not a high myope, I prefer not to leave the patient aphakic, because when I'm putting the oil, doing an, you know, air oil exchange or a PFCL oil exchange, you know, managing the anterior chamber becomes a little more trickier. So I prefer not doing that. So if I can
Same
put the
here.
lens,
So
I would
IOL is always preferred.
Okay.
Later also what happens is due to the inflammation and all, the iris tends to stick to the capsule if you have left them aphakic. Then putting a secondary IOL later and all, you know, removing those adhesions becomes a little bit of a messy situation. So always better to put in a IOL.
Anything like any power compared to the left other eye or something, but we'll try to put an IOL.
Yes.
Thanks.
So my next question to Dr. Muthukrishnan. So is it compulsory to use PFCL to flatten the retina in GRT, or especially when there are no rolled edges and all, or we can, you know, just manage with fluid air exchange?
No, we always prefer PFCL in all cases of GRT. Apart from unrolling of the GRT, it also helps to keep the horns and the edges attached and facilitate the steamroller effect to push the subretinal fluid, and also approximation of the edges for better laser. And in fact, in our center, Arvind Madurai, we also use an endotamponade for 5 days, a short-term endotamponade post-operative of 5 days. So we retain the PFCL for 5 days. This takes care of the GRT very well. GRT RD with CDs or with PVR is taken care well. And after 5 days, we go for a second, we fill it with PFCL, at least 70% with PFCL, and then top it up with little oil. And the second surgery, remove the PFCL, complete laser, if any pending laser, and then fill it with oil. And we have published evidence of 74 cases. So this narrates a study published in Journal of Vitreoretinal Diseases. So 74 case of GRT with 2-stage surgery, doing very well. So there's very limited, there's no risk of slippage in the.
Yeah, so I think we lost Dr. Muthukrishnan. So yeah, so basically he's talking about the sandwich technique where we inject PFCL first and then you put oil and wait for 10 to 15 days, and then in a second stage you remove the
We wait
PFCL
for
completely and
5
put
days.
oil. Sorry, 5 days. Oh, you're doing it
Yes,
in
5
5
days.
days now. Yeah.
Yeah.
Oh,
Yes.
yeah.
Very good results with that. So
Okay.
PFCL is preferred, and we believe it's a must for GRT RDs.
Okay. So anybody else doing the sandwich technique? What Dr. Muthukrishnan just described?
Yeah, I did that in one case, and actually it helped a lot. And I
Of
left the
GRT.
on GRT in GRT.
GRT. Okay.
So I normally don't use PFCL, but in GRT I usually like a couple of cases that I have done, and one of them actually I left the PFCL inside and then replaced it with oil after 5 days.
Okay. So complete replacement with oil.
Yeah. So the after
Yeah.
5 days it was complete replacement.
Replace. Okay. All right. So we have another 2 minutes till it becomes 9:30. Anybody wants to ask any more questions to the panel regarding this case? Okay, it's fine. So we'll move on to the next case by Dr. Aarti Mohan Kumar. So she'll present another case of giant retinal tear. Very interesting post-op result. Yeah, Dr. Aarti, please go ahead with your case.
I hope my slides are visible.
Yes, it's visible.
Very good evening to one and all. I thank Team LNR for giving me this opportunity to be presenting this case. So my patient is a 65-year-old male who presented with complaints of sudden drop in vision in the left eye for a week. His systemic history was significant for diabetes and hypertension, which were well controlled, and he had undergone cataract surgery in both eyes in our center 10 years ago. So on examination, his right eye was within normal limits. His left eye vision was hand movements and and was pseudophakic. He also had marfanoid features. He was quite tall with wide arm span length. So fundus examination revealed a temporal giant retinal tear extending from almost 11 o'clock to 6 o'clock position with early inner retinal wrinkling, and the macula was off. So considering the clinical picture, I proceeded with the plan for pars plana vitrectomy and silicone oil injection. So this was a case which was done quite early in my career. I used 23 gauge non-valve cannulas for this case. So this will be the surgical video. So I initially started the case by doing core vitrectomy. And once I tried to clear the vitreous near the retinal flap, and also I trimmed the anterior flap of the GRT completely. It was also done using indentation, which I have not shown here because of the low quality of recording. Then I tried to remove the vitreous near the horns, and then I completed the vitrectomy over the attached retina. A complete peripheral base dissection was done with scleral indentation. You can see following vitrectomy, the retinal flap flows freely. Then I used a PFCL bubble to gently unroll the flap and place it back in position, which I did not have face any difficulties. Following which I started doing laser to the horns and the edges of the GRT. So my plan, as discussed in the earlier case, was to laser near the tear, laser the horns, and complete a 360-degree peripheral laser. But then I was surprised by the formation of choroidal detachment in the supratemporal quadrant. So this, what had happened is in the process of indenting and lasering, the infusion had disconnected from the trocar, which me and my assistant had failed to notice. So after that, we reconnected the infusion, filled more PFCL, and then I completed as much as laser possible. But then the temporal shallow CDs persisted, which is not seen here because of the visualization. But in this area, some shallow CDs were still persisting. So I was worried maybe if the CDs start becoming more, the retina will start slipping. And I decided to go ahead with a fluid air exchange to see if the CDs will settle. But as you can see, the temporal CDs are persisting even when I filled with oil. I put the patient on oral steroids, and luckily for me, the patient did well in the post-operative period. The shallow CDs resolved completely, and he did quite well for 10 months post surgery, where his best corrected visual acuity was 612 with a hyperopic refraction. And he was doing quite well, and I told him no, he wanted to go in for an oil removal, but I kept deferring it because of the difficult post-operative course. I had used a 5,000 oil for this case, and I was not yet ready to remove the oil. But to my surprise, he presented almost a year later with light perception vision. He had undergone silicone oil removal elsewhere. There was, except for the lasered 360-degree lasered area, the retina was completely detached with extensive PVR changes, and there was a huge macular hole with everted edges, which was almost 2 to 3 disc diameters in size. So at this point, I advised research under very guarded visual prognosis, but the patient was not ready to go ahead with the same. So he is status quo as of now. So the challenges I faced during the surgery was intraoperative CD development, which was due to the, of course, slipping of the infusion during the process of indentation, which I had failed to. But then my scare at that point was, will that CD cause the slippage of the GRT? So that led me to take a decision of doing a fluid air exchange to see, because the more PFCL I was injecting, the disc was becoming pale, but the CD was not resolving. So I thought maybe fluid air will give me more control and may lead to the resolution of CDs. So that was my thought process when I did a fluid air exchange. And I do not know if the patient underwent ILM peeling along with the silicone oil removal, because I'm not able to explain that macular hole. And again, the advantages and disadvantages of doing a PFCL oil and an air oil exchange. Thank you.
Thank you, Dr. Aarti. Very unfortunate post-operative outcome, especially after all the hard work. But with retina surgeries, anyways. So we saw her case, and so let's start from the beginning. So she did a direct, fluid air exchange. So if there is any retinal slippage intraoperatively, how would you manage that? And this question is for Dr. Muthukrishnan. So how would you manage if there is a retinal slippage in a giant retinal tear, especially
Yes.
when you're doing a direct exchange? When
So
you're doing a
firstly,
fluid air exchange. Yeah.
yeah, I'm getting it. I got it. So firstly, we should aim at prevention of slippage. So thorough removal of the wedges is point number one. After which the subretinal fluid should be aspirated carefully with a flute. The horns should be dry. Edges of the GRT should be dry, and fill it up to the brim with PFCL till the aura if possible. And we can start laser even in the PFCL filled globe as much as possible. Again, and post-operative, as I already mentioned, we prefer endotamponade. If GRT with CDs, like in this case, better to go for 5-day endotamponade with PFCL. That again helps to prevent slippage. And if it slips in the process, then you'll have to remove the PFCL and repeat repeat fluid exchange. And, the post-operative PFCL days. These are the
We couldn't hear you the last part. I think your voice was breaking. But yeah, so the technique what Dr. Muthu is saying is that when you have the CDs and he'll do the same PFCL silicone oil sandwich technique. Yeah. So so we go to the next question. So here question is to Dr. Animesh. So what was the cost for the intraoperative CDs? So Dr. Aarti mentioned that the
Yeah,
infusion was detached.
infusion.
So
So
yeah. Anything else? So how to prevent that, and any other causes you feel can happen which causes intraoperative CDs to develop?
yeah, so most common cause for intraoperative CDs, especially in the small gauge surgeries, 2320 trocar cannula surgeries, is actually that retraction of the infusion cannula. So that is one of the most common cause, which you don't see in the 20 gauge surgeries. Uh, Other than that, in 20 gauge surgeries, and even in this, hypotony can be one of the most common cause for intraoperative CDs. If there is a lot of hypotony going on, so then also there is effusion of the fluid in the choroid. And then you have some risk factors like high myo, those who are predisposed to, there is inflammation, intraocular inflammation is there, not in GRTs, but as such, if the eye has inflamed eye is there. So other risk factors are there where CDs can happen. Most important thing is when the CDs happen, you immediately, like you decrease the, you take care of the hypotony, you check your cannula, and you raise the pressure inside the eye and you wait. So don't keep on doing the surgery, don't keep on doing the vitrectomy at that time, so that it does not progress further. So you wait for some time, few seconds, let it settle down and let it stop at least there, and then carry on. Because once CDs start happening, they can suddenly increase if you keep on doing your surgery, and the hypotony actually will increase the CDs further. So you close the, you take out the instruments, keep the infusion on, check your infusion cannula, and then increase the pressure inside the eye at least.
Okay. So we have a question in the chat box regarding the CDs. So if it's not resolving even after taking all the, and you have checked your infusion and all, and if it's not going, would you drain it intraoperatively, like an external drainage?
It depends on how much is the CD. If it is in the periphery, not going to the macula or anything, so I would prefer not to tackle it at that time and leave it, because I have seen those CDs usually, peripheral CDs, they will resolve with time. If there is no fluid, so if there is a kissing choroidals or something like that, then you have to drain them and stop the surgery, not keep doing it, and then maybe put the tamponade in the PFC and leave it there, and then take on after 5 days.
Okay, great. So my next question is to Dr. Komal. So we saw in Dr. Aarti's case the PVR developing and later. So my question is, would you do a prophylactic belt buckle in cases with giant retinal tear, like a 42 band or a 240 band? Have you done? Do you prefer
Honestly,
it in the primary surgery? Yeah.
honestly, in cases of GRT, usually I have not done, and I usually don't do it in a lot of cases unless and until obviously there's some other pathology which is going on. Like,
Okay.
I remember there was a case that I tackled, which was actually an FUVR. The FUVR usually has an avascular retina in the periphery with small holes which are there in at the junction of the avascular and the vascular retina. But in this case, surprisingly, there was this huge tear which had happened, which was almost like a GRT, but not really a GRT. It was just a huge tear of around 2 to 3 clock hours. So the surgery sort of went off like how you usually manage GRT. But in this case, because of that particular avascular retina which was there, I knew I will not be able to do or tackle
Maybe.
this thing, the peripheral shaving part of it as much. I had put a belt buckle. Again, in cases of those syndromic vitreoretinopathies which can present with GRT, but again, they have more posterior GRTs and can have multiple lattices all around throughout the fundus. In those cases, sometimes I would prefer putting a belt. So depending, honestly, on the rest of the pathology of the retina, not really primarily for the GRT.
Yeah, okay. So anybody else here who has an experience with putting belt buckle in GRTs? Not the syndromic ones, the general ones. Any of the other panel members, Dr. Animesh, Dr. Muthukrishnan?
So
No.
anything above 4 clock hours, I don't put belt buckle. But up to like if it is like 2 to 3 clock hours, then usually it's not like a GRT, it's more like a large hole. So otherwise, I put belt buckle in all my regardis except these giant tears.
Yeah, okay. All right. So we go to our next question. So we had already discussed about the endo laser. So now let's go on to something regarding how to prevent post-operative PVR. So any role of methotrexate in GRT surgeries? My question to Dr. Animesh here.
Yeah. So like PVR is like our like enemy for the retina surgeons and like for the for detachments. Uh, I had very extensive PVR in one case. I read after that for the methotrexate, and there have been lots of some case series, some randomized control trials are also going on now, and they have seen the efficacy of methotrexate in preventing PVR. The only problem is you have to use it more like regularly. You have to give injections almost weekly because the chances of PVR are more at day 30, day 90. They don't the PVR doesn't happen immediately after 1 or 2 weeks. And the intraocular methotrexate has a very short half-life of say 6 to 7 hours. And after that case, I have methotrexate in my OT. So I keep one ready. I haven't used in any case, but if I would definitely do that in my next case where I think a GRT comes or there is already an extensive PVR initially and I'm doing a surgery in a PVR RD where I think that the PVR is going to happen again. So methotrexate, because we cannot do much about PVR. We don't have anything for PVR. So anything that will help is a good thing. Methotrexate, what they have said is there are many methods that people have used. They have put methotrexate in infusion bottles also and not give injections later on. But what I think is that is kind of a bolus, but it washes off and then may not prevent PVR that well. So a better option would be to put intraocular methotrexate at the end of surgery and then give injections weekly after that.
So the same question to Dr. Muthukrishnan. I think in Arvind Madurai, they're doing a lot of methotrexate. Dr. Muthukrishnan, if he's there, your experience? Okay, I think he's logged out. So, Dr. Komal, any experience with methotrexate?
Not much. I've just used it in one case, that also over silicone oil. I'm not sure how it is gonna like really. Oh, it was basically a recurrence after a huge GRT, almost 270 degrees of GRT, which was operated elsewhere and had come with, the retina absolutely flabbed under oil. So it was a difficult surgery and I just didn't know. I just didn't want to operate it again. So had put still under follow-up, hasn't developed any PVR, whether it's due to methotrexate or something else, I'm not sure. So don't really have a lot of experience with methotrexate.
Methotrexate, okay. We have another person from Arvind Madurai, Dr. Atul Putalat. Dr. Atul, do you have any experience with methotrexate in GRT?
Hello, sir. Am I audible, sir?
Yeah, audible.
So we are regularly giving methotrexate injections for cases with PVR, and especially if there is suboil bleed. So when the bleed resolves, it tends to have less fibrosis. So we are having seen very good results with methotrexate, and we repeat the injection every week until at least for 4 weeks. So we are developing a case series, and they are doing well. So methotrexate can be advocated.
So you stop after 4 weeks or you still continue after that?
The maximum we have given so far is 4 weeks. Most of the cases resolved by that time, and the fibrosis tends to happen less, and the blood clot is mostly relieved.
So you are using mainly for the clots, bleeds, not as a method for preventing
Also for
PPR?
PVR, pre-op dense PVR to prevent anterior PVR in some cases, and the GRT cases also, if we feel that membranes have not come out fully and some leftover vitreous is there, to prevent excess PVR formation also, we are giving methotrexate injections.
So these weekly injections you are giving inside the oil?
Yeah, into the oil, yes.
Into the
Yes.
oil.
Oil, right?
Yes.
Into the oil.
What would be the dosage?
For 400 micrograms.
Okay, so what I had read was like anywhere between 200 to 400 micrograms is good.
Yes, yes.
So 250 usually I have a 50 milligram 25 milligram per ml of the vial. So you just so I'm using actually 250. I lucky what I planned was a 250 microgram, because you just dilute it 0.1 to 1 ml, 10 times dilute that directly and inject 0.1 ml.
Okay. So for all the beginners and also the main thing is that methotrexate half-life is lasts only a week. That's the reason for why you need to give repeated injections. Anyways, so we have an interesting question in the chat box, and it's like the hot topic now in all the retina forums and all. Now somebody is asking, would you do PNR for this cases of giant retinal tear? If you're doing how many clock hours, you'll do a PNR, and how many beyond you won't do? Anybody from the panel would like to answer that question? No, I guess nobody is doing PNR for GRTs, because I guess after the PNR, if it fails, then the PVR happening after the PNR is much worse than what you kind of expect. All right. So anyway, so coming to one of the final questions, if you're putting oil for, you're putting oil for all the giant retinal tear cases. So in your primary surgery, what is the centistroke of oil you'll use for all these GRT cases? Would you go for 1,000, 1,500, 1,300, or you'll directly put 5,000 oil? And if you're doing the sandwich technique, what is the centistroke of oil you're using in those cases? Dr. Komal or Dr. Muthukrishnan, Dr. Animesh, any of you can answer.
So usually in my primary cases, for my routine reg RD as well, I use 1500. So that's what I'm using for my primary GRTs as well. But if it's a GRT, suppose status post cataract surgery where the eye is already very inflamed, or if the GRT was very huge, like the one that I talked about of more than 270 degrees, or if it was just a small part of retina which was attached, and that also I had to cut. It basically becomes a 360-degree retinectomy sort of a situation. So in cases like that, in primary surgery, I would probably put 5,000. Otherwise, usually 1,500 suffices.
1,500. Okay. So Dr. Muthukrishnan, in your sandwich technique, what is the centistroke of oil you use for those cases? Dr. Muthukrishnan is there?
He's there, but
Yeah. Dr. Muthukrishnan. So what is the centistroke of oil would you use? I think he's not audible. Yeah, Dr. Animesh, how much of centistroke of oil you'll use?
I'm using 1500 for all my cases. So I usually, yes, because what I think is in GRT cases, if the retina has to detach, it will detach under oil also, and 1,000 cent, even a higher centistroke oil. Like it's hardly that you keep the oil inside for a long time. You don't have to keep the oil inside for a long time, because if it has to detach, it usually detaches under oil also, and then you have to go in again. Otherwise, if by 4 to 6 months it has not detached, then I usually remove the oil.
Okay, all right. So one final question regarding Dr. Aarti's case. So why do you think the macular hole happened towards the, I mean, in the post-operative period? That's a very intriguing uh, post-operative finding which happened. I mean, developing a large macular hole after the removal of the silicone oil. So any of the panel members would like to take that, the pathogenesis of why that macular hole could have happened.
See, like Dr. Aarti said that the oil removal was done elsewhere. So we don't know whether they had tried, there was some ERM or something which they might have tried peeling at the time of oil removal. And then there might have been injury at that time also, which could have caused some macular hole formation at that time. Because otherwise, at 10 months post-op, what the image that we had seen, it was quite clean image, and from there to that rolled out edges of the macular hole, and so that was quite kind of a shocking. So maybe there was something happened during the oil removal uh, that could have led to that.
Yeah, like
Otherwise,
iatrogenic.
yeah, kind of like iatrogenic kind of thing.
Yeah, it seems
Because
yeah, iatrogenic because the morphology is also very weird. It's not like a
Yeah.
stretch mode or something that would usually develop,
Yes.
and
because
that
the detachment is from the hole itself, the periphery, the edge where she has lasered, it's all attached and it's still there. There's no even PVR, what we say, it's all subretinal PVR. There is no pre-retinal PVR, even that. So I think could be because could be an iatrogenic hole also. I don't know.
All right. Iatrogenic injury, probably because of this thing. Great. So we still have another 7 minutes left, and one of the questions in the chat box, this is basically for all the juniors and vitreoretinal fellows, is what is the technique you use for PFCL injection? Would you use a double bore cannula, or would you directly inject and you tell the sister to cut the infusion, or open the infusion up when you inject the PFCL in these cases? Dr. Komal.
I usually inject directly and I ask the assistant to actually reverse the cannula. That also gives me an idea that my infusion port is actually open. I mean, it's free flowing sort of. So I reverse and I see if the fluid is egressing back. So that also helps to keep the pressure of the eye, in control. I have not really used dual bore.
Dual bore cannula. Yeah. Dr. Animesh, same technique?
See, I use PFCL very, very rarely. So maybe in last 11 years of my private practice, I might have used PFCL 3 or 4 times maximum. And my most of the cases, majority cases, I still a lot of cases I'm doing 20 gauge also. So there's a good advantage with 20 gauge, because if you're injecting PFCL in the 20 gauge, the ports are not that sealed, and the increase in the intraocular pressure is not like in the valved trocar cannula cases. Because here, even if the light pipe is there, you can see the fluid egressing out from the light pipe port also. So it's injecting PFCL is not that big a challenge in 20 gauge, but yes, in 23 gauge, like Dr. Komal said, that even the reversing the infusion cannula is a good technique where you reverse the infusion cannula, and you can see the fluid going back, and don't have to exactly clamp or stop the infusion at completely.
All right. So yeah, so that's the technique which we all use for injecting PFCL. Even I do the same thing. The only thing with the dual bore cannula is, first of all, it's a little bit expensive, and the injection is a little bit slow because the ports are a little small for the egress of the fluid back from those ports. All right. So one question by Dr. Sharath: how to reverse infusion? Dr. Sharath, if he is there, what is that question? How to reverse infusion?
I guess he's asking when I'm saying that, I
Yeah.
reverse So I guess
Yeah.
so what we usually use here at my this workplace is, we don't directly put the infusion. The infusion is actually connected to the, what do you call it? The three-way cannula. And so
Okay, okay.
because it is connected to the three-way cannula, you can actually reverse it.
So usually we just stop the infusion, and usually you can see the egress back from that infusion also, the constellation what I use. When I put
Okay.
we stop also, it goes back
Yeah,
in the
I mean,
infusion cannula that
you
I
can do
see.
that as well. Yeah. So
Yeah.
that is what we used to do back in LVP, but now slight modifications have happened.
Yeah. Great. So we have another 4 minutes left. Any questions by anybody, Dr. Aarti, Dr. Zakia, regarding your cases? Any other questions? Anybody who's here wants to ask?
Just going through when I was like going through this for this session. So what I think is my suggestion will be for the surgeons, retina surgeons, to keep methotrexate in their OT. So my plan is that from next time, so I'll try injecting methotrexate in such cases, because when PVR happens, you feel so helpless, and and it's a very cheap thing. It's easily available and can easily be injected in the silicone oil itself. When the patient comes for the post-op, you don't have to even take him to the OT. Maybe even you can inject in a minor OT, just like an intravitreal small injection is there. It's a good option. So I have that methotrexate in my OT now all the time.
How can you how do you explain to the patients who are not able to come then every week to kind of inject, they're staying quite far. Regarding the counseling part, what do you explain to them?
So the thing is, the place where I'm practicing, so in Patiala, so the cities are not that far away. So patients maximum say 70-80 kilometers or maximum 100 kilometers. So once a week coming for them is not that big an issue. So maybe if they are coming from very far, then it might be an issue. But still, usually we follow up after a week or 2 weeks. So if you are not injecting after every week, maybe after every 2 weeks you can inject. So as such, you follow up next day, and then after a week, after 2 weeks, you do follow up. So what I think is something is better than nothing. So being helpless completely and seeing the PVR set in, so can be a good option.
Okay. Great. So so we have almost reached the end of the session. So we had a great presentation and a great discussion. Presentation by Dr. Zakia and Dr. Aarti, and discussion with our panel members, Dr. Animesh, Dr. Komal, and Dr. Muthu Krishnan. So we discussed quite a bit right from the basics, starting with doing a proper vitrectomy, putting the PFCL, how to put it carefully, putting up till the edges, then doing a direct silicone oil PFCL exchange, tips and tricks for that, how to do it, like when you change the infusion, putting in your light pipe and using the soft tip. Also, we also discussed regarding the unfurling of the edges of the giant tail, especially when there is shortening, techniques to unfurl it using the soft tip, and Dr. Komal also mentioned using the bimanual to manipulate, especially when there are membranes at the edges. So, and then we also discussed regarding prevention of PVR using methotrexate and weekly injections. Injection post the surgery, as well as giving weekly injections till the time, at least for continuing for 4 weeks. And Dr. Muthukrishnan as well as Dr. Atul also pitched in on that. And we also discussed the other techniques, the sandwich technique, where we use PFCL and then we use the silicone oil on top. And then after 5 days of surgery, we completely replace it with oil. So great discussion. And we also had a question on PNR, and all of us were silent because very dangerous to do for GRTs. So, yeah. So anyway, so thank you, everybody. So let's finish off this session and a great presentation. Hand over back to Dr. Avnish. Dr. Avnish?
Yeah, thank you, Dr. Sashir, and thank you all the panel and the speakers, and thank you all our viewers as well. We'll come back with another topic, and thank you all for that. Thank you, everyone.
Thank you.
Thank you.
Thank you.
Thank you.